in there about, I love the word asynchronous, because that's the point, isn't it? Like you, Sally, I have a watch list, or I can send myself a reminder task in the GP practice. But it's that asynchronous. In other words, it could come back at any time from anybody else, but I can choose whether to pick it up or not. And I think that's where we have to use IT, because yes, it would be great to go for a curry, but that isn't, and we've talked before, haven't we, about mind lines, about the coffee meetings and how important that is. But this is much more than that. That is that kind of continual, if you want it, I'm not saying it has to be forced into you, but if you want it, you can get it, which also talks to your point earlier about how do you spread things, isn't it? And you said about continuous audit. You know, when I worked in the warfarin clinic, that was the best example of getting continual feedback, because I got to see whether or not my change in the warfarin made a difference to that person's INR. And I discovered whether they'd gone into hospital and bled into the brain, or whether they'd had a stroke, which is why I get so agitated about single organologists and not seeing both sides. They become blinded, as you said, Sally. So that's why I think I'm so impressed with it, but I realise there's a long way to go.
I agree with that, Steve. I suppose my other thought about it was, how would we create a filter? So there would be a danger of information overload, I guess. Do you want to know the outcomes of, 50 people that you've dealt with that day? Or is it only the adverse ones that you subsequently get referred into hospital? Or, what's the filter for that learning cycle, I suppose? But I guess with new techniques in technology,
AI algorithms.
Yeah, absolutely. Yeah,
I'm absolutely sure it could filter it in such a way that it would give you a balanced amount. Like you said, it can't do everything, but if you get nothing. So I think it's the future. I realise it's complicated and difficult, but I've seen, as we all have, about the power of feedback. But people love it. But then as soon as your study finishes, they go back to how they were before.
When I read it, I was just wondering about the patient would be surprised, wouldn't they, and shocked at how little feedback there is in the system. And that is one of the things that I sort of read it from that lens. I used to use running a workshop exercise, and I would go to great lengths, but it would end up with, how do you know you've been a good prescriber today? And it would be, well, they didn't come back. And for now, with community pharmacy doing more and more, is how do you know that you've made an effective intervention? Well, they didn't come back. But that's not good enough, is it? And so that's the bit. But as part of that, I read it alongside a Harvard Business Review article on the feedback fallacy. There's something more about feedback between two individuals than just the IT system, which Gimmo was sort of alluding to. And yeah, it's tricky, feedback is. It's tricky. People think they can give feedback, and people think they can receive feedback, but there is much, much more to it.
One of the other things I'm interested in relation to this is patient-facing technology. So how radical would it be if it was actually the patients that told us how we did?
Yeah, you could add that in. It would be another stream, wouldn't it?
Patients, interestingly, weren't listed in this particular, were they? They went through a whole range of other professionals, but they didn't mention feedback from the patient.
But just on that point, one of the biggest drivers of quality in I know it's completely different in the retail world, is the fact that everyone can feedback publicly on the service they received, can't they? And anyone can read their feedback on anything. We don't necessarily have that level of, it's difficult, but we don't necessarily have that level of transparency in healthcare, do we? Where people feedback like that. What
then, Sally, about the PROMS stuff that you're very keen on as well? That sort of fits into this a little bit, doesn't it?
Yeah, it does actually. Particularly if you were thinking about the impact of a medicine you prescribed, as you were just saying, because a patient-reported outcome measure is essentially just a structured communication, isn't it, about symptom burden and quality of life, which you can track over time. So if you have given somebody a drug and they asynchronously, Steve, ping their PROM back to you. See what I did there?
I'll pick that up later.
It is actually, it can be quite a useful tool for remote management, or if you're managing somebody's chronic pain, for example. I'm quite interested in how you might incorporate PROMs, not just to look at the effectiveness of the service or the effectiveness of a drug that you give somebody, but to actually support the model of care, so that you're not necessarily having to physically see the person or phone them if they don't want to, and if they're doing okay, they can track their own progress and this kind of thing. It's really, really useful. It's also really useful in terms of, let's say you're trying to get good, timely titration of heart failure meds after diagnosis. You want to get that titration done in an optimal time frame so that you can get the person back to physical functioning as quickly as possible. Using the PROM to track that can really help you to understand how you're optimising. So I think PROMs have such a rich use. I think we've still got a long way to go with embedding them and developing them further with patients, I would say, because a lot of the PROM tools that we're currently using were developed for use in the research setting and can be a little burdensome. So I think we'll see a big evolution in this field over the next few years.
And just for the listener, we've called them previously POOs. Jonathan Underhill from NICE liked to call them POOs, not DOs, so patient-orientated outcomes, which is the same as PROMs, isn't it?
Are they the same?
No, I was just thinking that. I think PROMs are patient-reported outcome measures, so they're more based on the experiences as they report and experience it. So I think they're similar but slightly different.
Okay, yeah, got you. Yeah, the R's for reported, sorry.
Yeah.
And there was a piece, I think, in the BMJ, a letter, how PROMs could supplement and complement surrogate endpoints. And so people are struggling with the surrogate endpoints of trials now, especially the cancer trials and things like that. And surrogate endpoints aren't quite, what we want, but that's what we get. But you could now, with PROMs, you could complement that as well. But there we go. Okay,
POOs and PROMs then.
A big thank you to Sally for joining us on the Oral Apothecary and for sharing her stories, her desert island drug, her career anthem and her book. Coming up next time, we'll be joined by Professor James McCormack. James is a pharmacist and medication mythbuster and healthy skeptic at the Faculty of Pharmaceutical Sciences at the University of British Columbia in Canada. He has extensive international experience talking to health professionals and consumers about the rational use of medication. He also co-hosts the very popular weekly podcast Best Science Medicine, so he'll fit right in on the Oral Apothecary. We look forward to catching up with James next time. You can contact us via Twitter at Oral Apothecary. We're on LinkedIn and you can email us oralapothecarypod@gmail.com. Over to Gimmo for the final ingredient.
Thank you, Sally. That was fantastic. I just wanted to, I'm going slightly off topic, but I wanted to talk about the dangers of groupthink. So the term groupthink has been in the news lately, more specifically related to some of the decision making that has gone on around COVID at the high level of government, but we won't go there. I think groupthink is relevant to the audience of this podcast, as many of our listeners are involved in meetings, producing guidelines, and agreeing a consensus on advice. So groupthink is a psychological phenomenon that occurs when a group of people with a desire for harmony or conformity in the group. That desire for conformity results in irrational decision making. Cohesiveness in a group may produce a tendency in its members to agree at all costs. So this causes the group to minimise conflict and reach a consensus decision without critical evaluation. So the reason I'm talking about this is because Roy Lilly talked about it in his blog. And we've talked about Roy Lilly before. He does a very good blog on NHS management. So if you want to know that you're at the risk of groupthink, ask yourself the following questions. Are you in a team that attaches a high value on being united, is often cut off from outside influences, comes from similar professional backgrounds, is highly stressed and feels that disagreement will be seen as dissent? And if you are, then you are in danger of groupthink. So if you are in danger of groupthink, Roy Lilly offers some advice. Make sure you practice inclusiveness at meetings, hold devil's advocate sessions, use outside experts, encourage authentic dissent, diversity, and leaders should hold back on their personal opinions. So there you go, a handy set of guidelines to avoid groupthink. Does everyone agree?
This was a 3 Apothecaries production. Sound engineer Jimbo Slough. Original music Jamie Brewster. Artwork by David Baker.
Thanks for listening to the Oral Apothecary podcast. Warning, may colour urine.
This episode of the Oral Apothecary is sponsored by jamiehayes.co.uk.